for the benefit of students and others. So welcome everyone. It's a great pleasure actually to welcome Yolanda Eraso, who is research lead currently, just finishing a term of service in that role in social professions, and Steve Hills, who is a researcher and lecturer in business. And this is a great example of interdisciplinary research between his work in business and sport and hers in social research, health research. And it's actually an example as well. I'm going to let them tell you about this. But it's an example of where research that was ongoing, and we're supporting this through our funds to get it going, the Transformation Fund, where a partner asked them to switch to COVID research, which is what lots of the research councils are doing right now as well. So it also happens in terms of local London partnerships as well. So without further ado, let's hear from them about how that happened and why. Thank you.
Okay, so thank you, Don.
Please mute your mics, folks.
Thank you, Don, for inviting us to present on this series of talks showcasing new research, and Maniva and Anne for helping us as well in assisting in the delivering of our presentation. So as Don mentioned, we are our research has been granted Transformation Fund, and we are grateful to both schools, social professions, and the business and law for their support. So the research project we will be presenting today is about barriers and facilitators to adherence to lockdown measures in London communities during the COVID-19. I shall start my presentation with an overview of the project and on how we develop our research design, and then Stephen will be presenting our initial modeling factors associated with adherence to social distancing measures. As we all know, in the absence of pharmaceutical interventions to tackle the COVID-19 pandemic, governments have strongly relied on people's behavior to stop the spread of the disease. In other words, a critical element in reducing transmission of the virus was rapid and widespread behavioral change. And behavioral science is the discipline behind the interpretation and the planning process through interventions on people's attitudes and behaviors in relation to public health measures. And we draw on this discipline in our project design and interpretative framework, and I will be referring to some of those behavioral constructs later on in my presentation. Personally, I've been working in the area of adherence to medication for quite some time, specifically adherence to breast cancer hormone therapy. But medication taking behavior has a long established approach in terms of how we can explain and measure this behavior with a range of validated scales. In the case of respiratory pandemic like COVID, we have no specific scale to measure behavior adherence. And it's expected, obviously, that with these surgeon studies in COVID, we will have a robust set of scales at some point. But motivation, incentive, disincentive, or opportunity for people to adhere to a specific behavior is not easily measured in terms of a discrete set of specific attitudes or beliefs that can anticipate or predict actual behavior to adherence. So this was one of the first points that we arrived at when we started conducting a scoping review of the literature on respiratory pandemics. And for that, at the time that we designed this, there were only a handful. I think there were 3 studies in COVID looking at behavior. And then we draw on swine flu, SARS, avian flu, and influenza as our review of the literature. A second point from the review of the literature is that we found that although adherence is a core issue in the world's response to the COVID pandemic and plays a vital role in reducing mortality and overburden of healthcare systems, you must remember, protect the NHS, there were very few studies on adherence to lockdown measures in relation to previous pandemics. The third point we identify is that it is important to carry out behavioral research during a pandemic where actual behavior can be measured. So in that sense, we were lacking in sort of using, as you know, there has been a lot of relaxation of this measure and distance, social distancing, and so on. So it was good that we managed to carry out this questionnaire, this survey between the 1st of May and the 1st of June before things change. The second point is focus on community settings, and we explained that we are using here North London boroughs, Enfield, Islington, Hackney, Haringey, Camden and Barnet. Why we're using these boroughs is because our the funding was allocated for the partnership with Whittington Hospital, and these are the boroughs that the hospital serves. But this focus on local communities elicited other type of issues that we consider worth exploring. First, we consider that most surveys were national or international comparative studies, usually with a global scope, and we thought that inquiring into local communities will fill the gap in knowledge. Secondly, identifying local level boroughs and the responses and experience and needs in diverse communities in North London will offer us an opportunity to unpack these facilitators or barriers in relation to behavioural adherence and subsequently the design of tailored intervention, either to continue to control outbreaks of COVID, which, as you may know, many scientists are expecting to happen as of today, or for future pandemics. Thirdly, there's a local approach was contrary actually to government's centralized vertical approach to the management of COVID-19, where engagement with local public health and primary healthcare was minimal in terms of responses and management of this pandemic. And reviewing the literature on pandemics, we soon recognize the importance of engaging with community organizations in managing responses, whereby community and charities, civil society organizations, it has been argued, should have the voice, be informed, engage and participate. From the review of the literature, from the review of the literature, in behavior or behavioral science specifically, we can classify the preventative behaviors in pandemics in the following. Here I am adapting measures taken by the UK government. So preventive behavior, hygiene behaviors that include hand and surface washing, coughing or sneezing to the crook of your elbow or tissue, not touching mouth, eyes, etc. So these are the hygiene behaviors. Another set of behavior are the avoidant behaviors that includes avoiding public gatherings, public transport, work, schools, and compliance with social distancing measures. This includes staying at home, going out for essential supplies and the 2-meter social distancing rules, and shielding policy for extremely vulnerable people. A third of behavior would be management of symptoms. And that is, if you remember, seeking help from NHS, 111, first online, then the telephone helplines, but also included self-isolation for between 7 or 14 days for those people who have symptoms, and quarantine if living with someone with symptoms. This is for asymptomatic people, 14 days. These are different types of behaviors. Some are enforced by law, with the police having that right to act and issue fines, like gathering of people in parks and the streets, or having a house party, for example, or drinking at a pub. Some are voluntary ones, like self-isolation and quarantine. Some are personal, or a personal choice, like hygiene. Some are novel, like keeping 2 meters distance. Some require different type of frequency, like hygiene, and others imply different type of time, like staying at home was applied for a particular length of time until the relaxation of measures follow at different points. hygiene recommendation and keeping 2 meters distance among people continue, except the later that is going to come to an end on the 4th of July. So of all these behaviors, we are interested in avoidant type of behavior, and only the self-isolation and quarantine one, which is fall within the symptom management type. Some of the steps that we took in our design of the project, is in particular the questionnaire or our survey. So we look at the evidence of the literature, and some of the issues that appears in that evidence was that perceived lack of government competence, fairness in crisis response could lead to distrust and fear in the public, and conversely, measures that are easily understood and communicated through trusted informants, people tend to comply with those measures. Another point was risk perceptions on how individuals perceive the susceptibility to becoming infected or vulnerable. They feel how vulnerable they can influence individual protective behaviors. Conversely, uncertainty and perceived exaggeration in terms of the seriousness of the pandemic were also associated with reduced likelihood to adopt the recommended behaviors. A review of psychological impact, and notice that this is psychological impact, consequences of quarantine-only measures, conclude that inadequate supplies, financial loss and stigma, lack of emphasis about collective responsibility in self-isolating behavior were among the major issues or stressors for people. And previous research during pandemic also have stated that demographic variables predict health behaviors. So based on this evidence from the literature, we started to build also our survey. We also look at data and we look at some of the transport information at the time. So we knew that between March and April, we knew that people were starting to move more. Also, we use some Google community mobility reports with the use of park and supermarket and others. So we have a bit of an idea what was happening at the time. We also consider part of the agenda, research agenda, emerging one from British Medical Journal, recommending the need to research in these areas, in particular, current population levels of knowledge, anxiety, and trust in responding agencies, as well as attitudes towards public health measures, barriers and facilitate for public health interventions, including adherence to self-isolation protocols. So that was part of the, was drawn by Miki, which is part of the SAGE and independent SAGE group as important areas to research in terms of this pandemic. So based on all these elements and evidence and literature recommendation, we started to develop our survey. We identified theory-based frameworks to develop our questionnaire, measuring behavioral and environmental determinants associated with these two type behavior, the avoidant and management behaviors. And we used the theory of planned behavior and social-ecological model. I'm going to explain a bit about it in this slide. So these are the constructs that we have chosen to ask people. These are the constructs brought from the theory, and then we develop obviously our own questions in relation to answer to these constructs. So understanding demographic association, you see the column on demographic factors there. could be useful to identifying specific segments of the population to target intervention programs. Apart from the traditional sort of more demographic data, we collected some relevant to social distancing and self-isolation measures, such as housing condition, homes with multiple occupancy or multi-generational households, employment status, type of employment, and people who work from home, amongst others. On the other hand, we drew on psychosocial variables such as knowledge, perceived susceptibility, perceived control on the behavior, intention to perform behavior, social responsibility, trust in government and science, and social norms. But we wanted to explore if sort of decisions to engage in health promoting behavior were influenced by these psychological factors, but we also consider that individual psychological factors may not be enough to explain barriers and facilitators and actual behavior. So we know that most public health challenges are too complex to be properly understood and addressed from individual level analysis. So the influences and interaction of environmental conditions became also a focus of our interpretative framework. And we move in this sense beyond the intrapersonal level to explore factors associated with adherence at that environmental level, using some construct germane to the social ecological model. So because the socio-ecological model provide a useful framework from achieving this a better understanding of these multiple factors and barriers that can impact on individuals. So we can contextualize individual behavior. So the psychological factor mentioned before, in the green sort of column, and some other ones like interpersonal level. For that, we make use of one scale, a validated scale that is called multidimensional scale of perceived social support, that inquires into support from friends, family, and significant others. Then we look at community support from local council and charities, and we look at public policy as well, and measures taken by the government to support housing. You might remember the ban on eviction, and government financial scheme, the one that allows certain people to be in furlough. So the higher order social structure levels, network, community, policy represent factors outside the control of any individual person. So some of our research questions in the design of our survey have to do with these three areas. I mean, first, association between demographic and health promoting behaviors, associations between demographic variables and psychological variables, and then association between the psychological variables and health promoting behaviors. And then we did the same with the socio-ecological model, demographic and socio-ecological model. In terms of, I'm trying to run because I know they still have some, I don't want to overrun myself, and I know it's still 15 minutes. A brief information on how we design our study. We use a mixed method. We started in quantitative data, as I mentioned with the survey. This is a sequential method that it will inform our design of the qualitative research that will come in a second phase with interviews with people. We recruited through social media and borrows and Facebook pages and communities. We reach out to communities in order to get informants, and the data for the data collection we devised a bespoke survey instrument with only one validated scale, the one that I mentioned before, and we use a Likert scale or 7 points, strongly agree or disagree, and then yes, no answers for social factors or frequency of behaviors. So I'm going now to hand over to Stephen to continue with his presentation on some preliminary results, please. Stephen, if you are.
Thank you, Yolanda.
Yes, okay, thank you.
So if we move on to some of the preliminary results. So first of all, the participants. So as Yolanda mentioned, we focused on the boroughs that are served by the Whittington Trust, and we were able to collect data from the boroughs that are primarily served by the Whittington Trust in Islington and Haringey, and then we were able to top up our sample via the boroughs that are less served by the Whittington Trust. So we're quite happy with the distribution of the responses across the boroughs. In terms of the total number of responses of 681, we needed 380 to be able to generalize to our population in terms of sample size. So we exceeded that. We actually had over 700 responses, but we had to remove some responses because they weren't within the target population. So that took our total response down to 681 for the modelling. So first of all, just to go through the outcome variables that we're modelling and some quite interesting findings in terms of the actual adherence to social distancing. To put this in context, the ONS data has actually reported that when people are asked to self-report on whether they adhered to social distancing rules or not, 80% said that they did and 20% said that they didn't. And that's very much just a straight up binary variable of did you or did you not? But we've gone into look at this in a much more nuanced manner. So we actually asked questions about how many times when you went out for permitted reasons did you come within 2 meters of somebody, and we counted that as a low level violation. But then we also said how many times did you go out of your house for unpermitted reasons, which we consider high level because that's where somebody has deliberately violated the rules. Or how many times have you met up with others when you weren't permitted to do so? Again, we've considered that a high level violation because it's somewhat deliberate and conscious. And we also collected data across different periods of the lockdown. So there was the full lockdown period, and then we all remember the Sunday evening when the Sunday afternoon when Boris Johnson came on our TVs and told us about the first set of relaxations in the lockdown measures, and we cut off the data collection on the 1st of July when another series of lockdown measures were eased. So we got the first 2 phases of the lockdown. Looking at our outcome variables, we've made some distinctions and some comparisons between these 2 lockdown phases. So in terms of total violations, the mean number of total violations were 10.77 per person, and of those 10.77, the majority of them were low-level violations. So the mean number of low-level violations where somebody had gone out for permitted reasons but ended up coming within 2 meters of somebody was 8.18. So quite a substantial amount of the total violations. Then we looked at the number of high-level violations, which we considered going out for non-permitted reasons, something like Dominic Cummins, for example, or meeting others when you weren't permitted to. This was much lower. So the total number of high-level violations, the mean was 2.59. Those that left home for non-permitted reasons, the mean number was 1.92, and meeting others was 0.67. We didn't see major differences between full lockdown and eased lockdown, but where we did see some significant differences was in the high-level violations. So we saw an increase in 1.31 for all high-level violations, and the stay-at-home violation increased by 1.23 after the eased lockdown. So if you were interested potentially in what the impact of Dominic Cummins breaking the stay-at-home violations might be, you might look at this increase of 1.23, which was statistically significant difference at the 0.01 level. We didn't quite have a research design that was experimental, so to be able to attribute this statistical difference to Dominic Cummings, but just something of a little bit of interest there. What we also did was we then converted our count variables to binary variables, and we could see that adherence was only 7.2% when we considered all social distancing rules, including the low-level violations. So this is a huge difference from what the ONS are reporting, where they're saying that it was 80% adherence and 20% non-adherence. So this is, this is very interesting. And when we go into the see where these differences are, it was the low-level social distancing rule. So over 90% of people in our sample non-adhered with the low-level social distancing. So they weren't able to stay 2 meters apart when they were going out for permitted reasons. And then when we start to look at when people left their home for unpermitted reasons or unpermitted meeting of others. So if Professor Neil Ferguson had completed our survey, he would have he would have actually been in the next slide, because it was his lover came to his house, so he didn't leave his house, he just met somebody for a non-permitted reason. So we can see that here, that the number of people that left home for unpermitted reasons was 33%, which is astonishing compared to what the ONS data was reporting. And then those who engaged in unpermitted meeting of others was 28.8%. So these binary variables show us something very different when we're asking nuanced questions about specific behaviours, as opposed to asking the question of, did you adhere rules or not, where the majority of people, 80%, say they did, but when you're actually asking them about specific behaviours, you actually find something very different in terms of the adherence that we've seen within our sample. So moving on to the modelling, and from the previous two slides, we've got lots of variables that we want to model, but for this presentation, we're just focusing on the modelling of the total number of social distancing violations. Now, this outcome variable is a count variable, because we were asking number of violations. So because of that, we applied initially a Poisson model to the data. And what we can see here is, looking at all of our variables, which we've divided up into factors, i.e. categorical variables, and then covariates, so our continuous variables, and we considered our Likert scale data to be continuous, but we could have modeled that as a factor, but it's more convenient to do it as a covariate. We see that lots of our variables were significant predictors. However, unfortunately, when we ran the goodness of fit tests, although we found out that the model was significantly overall consistent from our likelihood ratio chi-square statistic with a significant level of 0.000, when we actually check the assumptions of the Poisson distribution, we find that the assumption of equidispersion, whereby the mean and variance of the model are identical, was violated, because we need a Pearson chi-square value that is close to 1 for that assumption to be met. The Pearson chi-square value of 6.678 actually tells us that there's significant overdispersion in our data, so the Poisson distribution does not fit our data, and this led to us looking for another regression model, and a regression model that can be used on count outcome variables and which does not assume equidispersion like the Poisson does is the negative binomial regression model. So if we now look at when we apply the negative binomial regression model, we see a very different picture, where we've now got 1, 2, 3, 4, 5, 6 of our variables are significant predictors of total social distancing violations. And we again see that this model is statistically significant with the likelihood ratio chi-square of 0.000, which tells us that all of the independent variables collectively improve the model over the intercept-only model. And we also now see that the data fits the model. So the Pearson chi-square value of 0.626 is over 0.05, indicating that the model fits the data well. So now we can continue with this distribution to actually try and refine our model and get something that predicts our outcome variables. So the next step that we took was to get rid of all of the variables that in the first state in model 2 were not significant, which left us with vulnerable health, perceived vulnerability, behavioral intention, control over leaving the house, control over others distancing, and support from friends. But when we ran this model, support from friends actually became non-significant. And although our Pearson chi-square value increased, showing a better fit, we needed to run another model because we wanted to take out support from friends, which would come up as non-significant. So when we do that, again, the fit of the data to our model improves up to 0.66. And we can see that we've now left with all of these variables that are significant predictors of total number of social distancing violations. However, we've got vulnerable health, which was a binary variable in terms of has the government informed you that you're a person with vulnerable health? And then we also had a psychological variable, which was perceived vulnerability. Now, obviously, these two variables overlay to some extent. So we wanted to check what happened when we removed one of these variables, whether the fit to the data improved. And because perceived vulnerability was more significant than vulnerable health, we kept that into the model, and that again improved the fit of the data. So this was the final negative binomial model that we were left with 4 predicting variables that were deemed significant. So behavioral intention, perceived vulnerability, control over others distancing, and control over leaving the house. So in terms of our theoretical framework, this is interesting because it shows us that the theory of planned behavior was important. Demographics were not very important, and one psychological variable was important, but behavioral intention, which is a component of the theory of planned behavior, and control over the behavior were also significantly important as predictors. So that shows that this is an important theoretical framework for understanding adherence to social distancing. We can then move on, and with that final model, we have these regression equations which tell us the predictive power of each of the variables. And if I interpret those on the next slide, we see that the number of social distancing violations decreases by 16.4% for each increase on the 7-point Likert scale for behavioral intention when holding other variables constant. This was statistically significant. So intention was the most important predictor, followed by perceived vulnerability. So the number of social distancing violations decreases by 10.6% for each increase on the 7-point Likert scale. And this was statistically significant. Also, for the variable that we removed, which was just whether or not you were identified as vulnerable or not, on a binary level, if you were vulnerable, that actually decreased number of violations by 30%. But that's not as predictive as this, because this is on a 7-point Likert scale. So just 1 point increased on the Likert scale decreases violations by 10.6%. For control over others distancing, which means when you go out for permitted reasons, the extent to which you perceive control over others coming within 2 meters of you, as control increased, number of violations decreased by 10.5%. And then the least predictive of our predictors was control over leaving the house. So as 1 point increased on the Likert scale, that decreased violations by 6.3%. So this is the model that we have for our first outcome variable, which is the total violations, but we've got a lot more to do in terms of all of the other variables that we're interested in. So we're still going to model the remaining count variables and then all of the binary variables, and considering the differences in the amount of adherence between the different outcome variables, we may well see some very different predictors coming into play there. So we're going to complete that modeling to conclude the quantitative phase of our study. Excuse me. And at that point, we're going to produce some initial quantitative reports to share with the partners that we've been engaging with, including the Whittington Hospital, but also some public health bodies that Yolanda's been engaging with. And then from the quantitative analysis, we're going to identify the factors of interest for the qualitative investigation. So this is going to help us identify the participants in the study that we want to follow up with telephone interviews. So those participants that exhibited high violations or non-adherence due to the factors of interest. And then once we've completed that phase of the study, we're going to write up some qualitative reports to share with our public health partners. So once we've completed that phase where we're sharing our findings with our partners, we're then going to move on to the academic literature, and we'll produce some academic articles targeted at Journal of Health Economics, and we might combine the quantitative and qualitative into single articles, or we might divide them up. We'll see how we feel when we've completed the investigations as to how we want to write those up. And then Diane, who's on the call, will be pleased to hear that we'll hopefully make this work part of a future impact case study, which is why we're actually focusing on engaging with our partners via reports before we move on to the academic literature. That concludes our presentation. Here's our references, and we'll pass it back to Don, and we're happy to take any questions that you may have.
Yes, thank you very much. That was really fascinating. Great to hear about live research. Of course, research that's still ongoing, but really finessed findings. And of course, please can we sign you up for statistical training packages for postgrads, because that was actually a real model of inference and correlation and whatnot. Took me back to my undergraduate days with Pearson product moment and chi-squared. I had a tear in my eye. Thank you very much. It was really fascinating, and not all the results were as we would have expected, just showing that so much nuance there. Would anyone like to ask a question? Please indicate by raising your hand. Klaus Fischer would like to ask a question. Klaus, the floor is yours.
Yes, hello. Can you hear me?
We can very well.
I was interested. I mean, thank you very much. I mean, that's a fascinating presentation and way above my head. But in the media, there was a lot of discussion about ethnic minorities being more at risk. But in your study, if I understood it correctly, you didn't seem to find a significant difference in violations. That means in behavior that might expose them to risk. That would be one question to comment on that. And the second one, I might have missed it, but did you use socioeconomic group as a variable?
I can take both those questions. So to take your first question, Klaus, yes, what we actually did was in our survey, we collected data on ethnicity, but we didn't get, from the 681 usable responses, we needed 30 per category to use that as a variable in itself. So what we ended up doing was collapsing the ethnicity data, and we recoded it to be BAME or not, and we found that wasn't a statistically significant predictor of social distancing violations, which is is kind of what I would expect. I can't think of a theoretical reason why somebody of an ethnic minority is more likely to violate the rules than somebody of a white ethnic background. So I think it's good to see that we haven't found that people of ethnic minority are more susceptible to the disease because they're violating the rules. You know, that would be quite a controversial finding that I would not like to stand behind in the current climate, certainly. So I think that is as I would have expected to see. And then in terms of your second question on socioeconomic status, yes, how we measured that was we collected every participant's postcode, and then we're able to run postcodes against ONS data, and it gives us a very comprehensive report of deprivation, and each participant had a 1 to 10 deprivation quartile recorded against them, and that was again not statistically significant for total social distancing violations, but that doesn't mean that it won't be statistically significant predictor for other outcome variables that we look at. Does that answer your question, Klaus?
Yes, it does. But if I may ask a follow-on question.
Yes, do.
I mean, there are sort of, intentional violations and involuntary ones. So would your survey have captured violations that come about because of somebody's profession? Because, let's say, as working in public transport, they cannot avoid coming close to people. Would that have been captured?
Yes.
Sorry, go ahead, Yolanda.
No, I think that it was captured in one of the questions because we consider the key workers as well, and going out for work, for not being able to work at home or being a key worker is data that we have, and I think that there's also, of course, there are lots of nuances. I think Steve mentioned that this is the first sort of running of very intense modeling, but there are other sort of iteration of this, and we will be looking at more granular information as well with other models that binary models in particular that will allow us to associate a bit perhaps more closely other variables, and in particular demographic variables, where you will see the people who are working as key workers or people who cannot work from home. And that, in addition to that, after we run more specifically those studies, we will be able also to feed into our qualitative research, because at the moment we don't exactly know why people feel vulnerable, for example. We don't exactly know what they feel. Well, we can anticipate somehow, but we need to tease out that information through interviews and to get a closer understanding of the motivations.
And just to follow up on that, as you can see from this table, we did collect key worker status as an independent variable, but if somebody came within 2 meters of somebody through their work as a key worker, that is not considered a violation of the rules because it was through their work. So that is not captured as, that doesn't count as a violation or non-adherence to social distancing rules, because it's within the rules that if you're a patient, that you are coming within 2 meters of somebody. Does that answer your question, Klaus?
Yeah, I think he said thank you before.
Okay.
Yes, it answers my question, and it's of course the risk might then lie in the profession, so but it's good actually to keep these apart, you know, because of course there might be, you know, all sorts of stereotyping of, you know, groups who would engage in riskier behavior, and your study seems to show that is not so. I mean, that, for example, ethnicity does not matter when it comes to violations.
Yeah.
Yeah, good point. Okay, well, thank you for that. That was a good discussion. And now Gary McLean and then Bal Verdi.
Yes, hello. Thank you for the presentation, Stephen and Yolanda. It was very nicely done and rather complicated for me to follow everything deeply. But I was interested when we see these infectious disease outbreaks. One of the factors that you can never really control into modeling how a disease will progress is human behavior, and it's nice to see how you've established some of those features here. And the other factor that's really important is the immune status of the population. Now, we know at the start of this outbreak, nobody was immune, but later on, presumably, people did become immune, particularly those who had had the virus before, and they're more likely to behave differently and break lockdown, if you like. And the two examples of people you gave, Cummings and Ferguson, both had the virus. So do you think, what kind of role is this playing in their decisions and even other people's decisions to violate the lockdown?
Yes, Gary, that's an interesting point and something that we considered. If you look on the factor explanatory variables, had COVID-19 symptoms was one of our predictor variables that was not significant for this particular outcome variable. So again, if you think about it, it could be significant, and something that I thought might have been significant. Everything that we've included here, we thought might be significant. We thought there was a chance for these factors to be significant, and it wasn't significant. So again, it doesn't mean that that's not going to be a significant factor in the other outcome variables that we look at. Because total social distancing violations, remember, 90% of people did violate all of the potential rules. But I think when we get into the outcome variables that were more 50-50 or 70-30, we're going to get some more interesting findings. And I think a lot of more of these predictive variables are going to turn green.
Yeah.
Great, thank you.
Thanks,
Okay,
Gary.
thank you, folks. And now Bal.
Very interesting talk. Did you capture the data on the ages of the population of the people you surveyed? And it would be interesting to see the analysis on how the ages compares with the overall picture in your analysis.
Yes, it's capture the age. We do have age as one of our demographic variables. I don't know, Steve, if you want to, at the moment, it's something that it will be interesting, as you say, because we know the same with gender. We know by some other studies that women were more likely to comply or to adhere to rules as opposed to men. We also know that, for example, teenagers or younger people under 24 years old were more likely also to not to comply with the rules. And I suppose in that second or iterations of our modeling, I mean, I suppose that we are hoping that this aspect, more granular aspect, will be somehow we will be able to associate or to test. I mean, when I say associate, it's just to look closely with our sample whether we can predict somehow or explain the behavior with in terms of adherence or non-adherence.
Yeah, just to add to that, we did collect age. It wasn't significant predictor, but again, that doesn't mean that it won't be significant for another outcome variable. And also, it's very important to say that this is based upon our data. It doesn't mean that age is not a significant predictor in another set of data, but based upon the 681 responses that we collected, it wasn't significant. And actually, the majority, one of the reasons that it wasn't significant is because we actually captured data from an older audience. So we didn't have a lot of variability in terms of a younger age group. So that's a limitation of this research, that for that particular factor, we didn't capture a great variance. And in particular, we didn't get a lot of responses from younger people, which is one of the reasons why a predictor might not be significant, even though in another set of data, it could well be a significant predictor.
Great, thank you very much.
Thank you, folks. And now Duncan Stewart has a question for us.
Hi both, thank you very much for a very interesting presentation. I've just got two related questions about exposure to risk. And forgive me if I missed it, but could you just clarify that the exposure for individuals in the survey was accounted for in the modelling? So I presume you had an exposure variable in the binomial model, and I'm thinking about this just in terms of the comparison with ONS. So you know, is the sort of recall period for your studies comparable to that of the ONS data that you've mentioned?
Thanks for that question, Duncan. Yes, very interesting. In terms of risk, we had two different variables. We had perceived susceptibility, so that's were they going to actually catch COVID, and we also had as a separate variable perceived vulnerability, so that's if they caught COVID, how much would they suffer. So that's it's probably, in terms of exposure to risk, susceptibility is probably the closest variable to what you're describing there, and that wasn't a significant predictor in this instance. And a very good point about the difference between the ONS data and our data is we did a 2-week recall period, and ONS did a 1-week recall period. So the difference between them reporting a 20% non-adherence to our 90% non-adherence it's the 2 weeks isn't going to explain that difference. But yes, you're right, there is a difference between the recall period of our data and the recall period of the ONS data. When we designed our survey, we didn't know that the ONS were collecting that data, and we didn't know what their recall period was going to be. So we just did what we thought would give us a more variance in our outcome variable, so to enhance our modeling. But we've already requested access to the participant level data that the ONS has requested, and is helping us with that application, because we need to get university level clearance to be able to access the ONS data remotely, because normally when I work with ONS data, I have to go into the secure environment in Victoria, but obviously we can't do that at the moment. So we've put in an application to access the ONS data, and we're working to get that accessed remotely so that we can be quick off the mark to analyze that data and get it out into the public domain, because I'm sure lots of other researchers got the same email that Yolanda and I got from the ONS telling us about the existence of this data and that we can apply for it. So we want to be quick to get in there, analyze it, and get it out.
Can I just add that to the question of perceived vulnerability and susceptibility? I mean, I think Steve has explained already that perceived vulnerability did have, in this particular modeling, presentation, it did have a significant association. And I think in particular that is capturing not people that feel simply susceptible for the disease, but people that feel that if they were to catch the disease, the consequences will be severe. So it's another level of risk that they are feeling. And that, of course, was positive in the sense positive. It's in green because it was associated with compliance or adherence with the lockdown measures. But I think that within that group as well, this is tapping into the question of Klaus at the beginning, asking for more at risk group, as we heard from the press and from studies as well. And I think that it will be interesting and relevant to understand why is that those people feel more vulnerable. And that will surely capture, I anticipate, I might be wrong, but capture those key workers and people who are exposed for their work or for the need to work, people who have become furloughed, for example, the need to work during the COVID period, and that they feel in that way.
Okay, thank you very much. Does
Okay.
anybody else have any other questions? We have one more, I think. Well, it looks like we're going to finish on time. Listen, that was really very good, very interesting. Great to see. Okay, there's a message flashing up there. Great to see this live research still ongoing. Really enjoyable. Thank you both very much indeed. Good luck with the rest of the research. We've just had one form of IT certification cleared. I'm not sure if that would help you. I don't know if Anne's forwarded it to you, but I will forward it to you if she hasn't. And anyway, we do know about your request to the ONS. So, all right, everybody. In 2 weeks' time, we have a scientist, Jamil and Al. But for now, we have a week off next week. See you all soon. Keep safe. Thank you all for attending, and best of luck. And thank you particularly to our speakers and to Anne for backing this up and being the secret organ operator in the background. Thank you all very much.
Thank you very much.
You,
Bye,
Thank
Crystal.
you.
Thank you. Bye.
Bye, everyone.
Bye.
Bye, everyone.
Bye.
Bye.